Greetings, everyone. It's indeed a great pleasure to come to you today and to be able to present to the Ukrainian Society on this occasion of their national meeting. I am very indebted to them, and I'm also very supportive of their activities. And I wanted to do something a little different this year, and it turns out that it was a very, very serendipitous decision because I've just come across an article that bears into this whole topic. So, what I would like to do is I would like to start by sharing my screen and talking about leg fractures and venous thromboembolism. Critical principles revealed. These are my disclosures. Now, I came across this article very recently, and it talks about the effects of aspirin versus low molecular weight heparin on orthopedic trauma patients. And it's a secondary analysis of the PREVENT trial. The PREVENT trial was a trial that was published in the New England Journal that was come to the conclusion that low molecular weight heparin and aspirin were equivalent for treating patients with leg fractures. And there are a number of discussion items that could be presented regarding that trial, but the most important of which was that most people realized that the trial had a large number of low-risk patients. So this study was published out of Johns Hopkins and Maryland by some very brilliant investigators. I've worked with all these investigators. I've given grand rounds at their institutions, and they published this study. And this study did a secondary analysis of the PREVENT study population, and they used the Caprini score, at least they claimed they did, to track thromboembolic outcomes. And they concluded that the Caprini score demonstrated that there was agreed indeed with the findings of the PREVENT trial that aspirin and low molecular weight heparin were relatively equivalent for prevention of clots. And by the way, of course, people preferred to take a pill instead of an injection. And this paper was submitted for continuing medical education for people to get CME1 credits. And I think it's really, really important that the proper information be conveyed, especially because of the teaching nature of this publication and where it was presented. Now, this is not the Caprini score. The authors did not use the Caprini score, but a risk index devised by the authors labeled as the Caprini risk score. The Caprini risk score, as you know, is 39 factors. They used 9 factors instead of the 39 factors, and tibial fractures were scored as 2 points rather than 5 points in the Caprini risk score. And that illustrates and points out the entire purpose of this lecture I'm going to deliver. The BMI was 30 instead of 25 in the CRS, and 3 of the factors that were included in this author-generated score aren't even in the Caprini score. And so the following presentation has been created to inform everyone about the dangers for VTE associated with risk fractures, and more importantly, why the Caprini score is scored as a 5. Now, we know the Caprini score is a thorough history and physical with 40 elements, and we know as the number of risk factors goes up, the risk of VTE goes up, and the power of each risk factor is also graded. And the combination of the number of risk factors and their relative weights results in a score, which is a nonlinear increase in the VTE rate with increasing score. And here are the results in general surgery. As of January of this year, there were 5 million patients, including PubMed listings of over 500 publications. Now, to illustrate a little better about why the power of the score is so very important compared to just listing risk factors, let's take a 42-year-old patient with a BMI of 29 on birth control pills. The Caprini score is 3. The patient has 3 risk factors. Let's take a look at a patient who's at 76, who has a history of a pulmonary embolus and past cancer. Caprini score 8, but only 3 risk factors. Although each patient has these 3 risk factors, the combination of number of risk factors and their power result in a more accurate estimate of VTE risk compared to a simple list of risk factors alone. Now, more than 100 years ago, the famous pathologist Rudolf Virchow described a triad of factors associated with the development of venous thrombosis. And as you can see from the triangle, when all 3 were present, the likelihood of thrombosis was very likely, and that's why we talk about 5 points. Here is the Caprini score listing, and you can clearly see this. And you can also see the multiplicity of risk factors that if you look at that publication I quoted earlier, they're not there. Now, leg fractures, a hematoma forms around the fracture, and that produces stasis. There's vascular damage. Just think if there's enough force to break the bone, think of what that does to the tissues. It damages the tissues, and that includes the veins. Also, when the bone is broken, the marrow is disrupted, and fatty elements enter the circulation, as well as tissue juice products as a result of the broken bone. And these factors increase systemic anticoagulation. So, vascular damage, venous stasis, pooling, and hypercoagulability. All elements of Virchow's triad are present in fractured leg bones. Force required to break the bone also damages the soft tissue, including blood vessels in the area. I'm being repetitive, but this is an incredibly important concept that's poorly understood, especially when it's a bone that doesn't need surgical intervention. It's classed as minor. It's not minor from the thrombosis standpoint. When the tissues are damaged, blood can escape into the tissues, stimulating blood coagulation. The bone marrow injury allows fat and tissue juice to enter the circulation, stimulating blood coagulation. And the hematoma forms a local collection of stagnant blood. All of these factors together make a clot very, very likely. And here we see a 1-power electron microscopic depiction of a dilated capillary, which is the smallest vein. And it's done to show that as the blood flow slows and the veins expand, overfilling the capillaries with blood, the endothelium expands and there are cracks that form. These same cracks can form when a fracture occurs because the tissue is damaged that's surrounding the fracture. And you can see in the cracks, blood clots can form. Now, this shows you a white cell that changes into an adhesion molecule as the flow slows, and you can see the darkened condition here. And when the flow slows or stops because of a fracture, what happens is that this adhesion molecule lands on the surface of the capillary, extrudes granules, which create an inflammatory response, which damages the capillary and makes it useless for the transfer of oxygen and nutrients. It also increases the possibility of a thrombosis. And here you see the actual experiment, and you can see here the adhesion molecule beginning to penetrate the wall of the capillary. Now, contributing factors. This is an ultrasound of the popliteal fossa and behind the knee, and the vein is seen here, and the artery is below. And as the leg is flexed, what happens is that the vein is compressed by the head of the gastrocnemius in many cases, and this shuts the deep vein flow out of the leg. And now all of the blood has to go around through the surface veins, which is much less efficient. And you all know about this because people that are standing at attention are urged not to lock their knees because they could produce this phenomenon and they could faint because of decreased blood flow back to their heart. Now, there are also contributing fractures to the injury. Presence of the fracture, surgical repair, especially if tourniquets are used, obesity, leg swelling, immobility, a straight leg brace, and poor absent weight bearing on the injured leg. This final point is critical and poorly understood. First of all, we've already talked about the fact that when the blood flow slows, when the popliteal vein is compressed by straight legs. So straight leg braces produce this. Now, ambulation is defined. We have a good definition of ambulation, and it's the presence of being able to walk 30 feet at one time using both legs. Critical. You have to use both legs. Now, if one leg is immobile, there's some beautiful studies in ultrasound by Craik that show that the blood flow in that leg is no greater than if the patient is sitting down. So if you have a patient walking with crutches, are they immobile? Well, if they're not weight bearing in one leg, yes, they're really immobile because there's no increase in blood flow out of that leg. And ambulation has been defined. This goes back to the year 2000. You can look the article up by Amin. and it'll indicate that if they defined ambulation as walking 30 feet using both legs. Also, the equinus position is also a risk factor for thrombosis and associated with reduced blood flow. These are very important factors, and you talk about AMA Category 1 credit. This is what should be in there as AMA Category 1 credit with the references as I've shown you. Now, what is the missing link? This is a critical thing in risk assessment, and it most often has not been addressed. And that's family history of venous thromboembolism in relatives. This is a large study that showed that if a person doesn't have a clot, but has a family relative with a clot, first degree, second degree, or third degree, there is in decreasing power the risk of thrombosis in that individual. There is also a slight increase in risk of individuals that live together, and that's attributed to people that live together often have similar lifestyles and so on and so forth. Now, that was all well and good in 2013, and it was largely ignored by the authorities. However, in 2024, a study came out identifying 482,185 pedigrees containing a mean of 14.2 parents, aunts, uncles, grandparents, and cousins of a core sibship that they termed the pedigree offspring, 750,000 people. And the pedigree, excluding the core full siblings, was then divided into 8 different clusters based on the density of venous thromboembolism. From these clusters, they predicted different venous thromboembolism manifestations, cardiometabolic disorders, and overall mortality of pedigree offspring. Deep vein thrombosis of the legs, pulmonary embolus, superficial thrombophlebitis, unusual thrombosis, and pregnancy-related VTE and thrombophilia were all significantly associated with the density of the pedigree. Family vulnerable VTE is broad and impacts other conditions, including thrombophilia, obesity, diabetes, gout, varicose veins, and arterial thrombosis and embolism, arterial thrombosis. What's the bottom line here is that if you have a patient who doesn't have a personal history of thrombosis, but has a family history of thrombosis, they are at increased risk for developing a blood clot. And you must ask the questions to find out what is their real history. Now, several of the risk assessment tools have thrombophilia factors listed, but not family history. And unfortunately, the 5 major genetic risk factors together account for only about 30% of family history of VTE. You must ask about family history in all degrees of relatives. And the Caprini score is one of only 2 scores in the world that track family history of thrombosis. The other is the British score.
Emily, I just wanted to tell you that I love you and I missed you today. A daughter is a mother's best friend.
Our daughter, Emily, was a UNF graduate and a rising star in healthcare.
She was treated for a fractured ankle at Mayo Clinic.
She died from a pulmonary embolism stemming from that fracture.
Find out the answer to this simple question.
What is my Caprini risk score? This simple question could save your life.
Now, I've shown this video because this dramatically illustrates that in a young, healthy person having a relatively uncomplicated orthopedic procedure involving a fracture still died. And the reason is this patient had a strong family history of thrombosis with 3 people in the family with a heavy history of thrombosis, including one that died. And this is a tremendous illustration to say why you must look at family history of thrombosis. And I would point out to you that it's very common today to go back and look at administrative databases and try to figure out who had blood clots and from that extrapolate into risk assessment. One of the reasons that it fails miserably is the fact that very commonly these large databases do not contain information regarding family history of thrombosis. If anybody in the audience finds one where the big database does show it, I'd love to see it. So in conclusion, the risk assessment procedure must be followed in order to prevent venous thrombosis, including fatal PE events. Family history of thrombosis is key. This element is frequently not queried. Fractures evoke all elements of Virchow's triad and often lead to the development of a VTE. The administration of prophylaxis helps to mitigate those factors and prevent VTE. Another thing that has to really be stressed is that the Caprini score and any other score that you use has to be dynamic. It must be updated during hospitalization and at discharge. Extended prophylaxis following discharge is important for patients with high-risk Caprini scores, including fractures. Continued prophylaxis is important until full weight bearing and mobility of the fractured extremity occurs. Remember, never never kill a friend, never treat a stranger. Perform a thorough history and physical so you have knowledge about that new patient or stranger. They're no longer a stranger. They become like a friend and you would protect them. You'd never hurt a friend. So please go to my website. There is much more information available, or my social media platforms. And in addition, the VWin app is a wonderful resource to get information regarding all of these things. Thank you very much. And to the people of Ukraine, I hope you have a wonderful meeting.